representatives from WHO, from UNICEF, from the African Council for Religious Leaders, and from Africa CDC. After the opening session, we shall get into the first session, which we are going to have as speakers taking us through Ebola prevention and preparedness. This will take 15 minutes. This will be followed with another 20 minutes, which we shall listen to religious leaders sharing with us the ongoing faith actions where they are. After that, we shall have session 3, which will be on community engagement and risk communications, and this will take 15 minutes. After that, we shall have a session where we'll be taken through safe and dignified burial practices. This one will also take 15 minutes before we get to the second last session, that is the question and answer session, which will take 20 minutes, and then we finalize with closing remarks and way forward. So by noon sharp, we should be done with this webinar. I now wish to take this particular special opportunity to bring in our distinguished speakers from different organizations to provide the opening and welcome remarks. And I want to begin, I can't see my chat box. I don't know whether we already have Dr. Marie-Rosaline from WHO.
I don't think she has joined yet, but maybe we could give the floor to Dr. Tolbert first.
All right.
Thank you.
Thank you so much. So I now wish to usher in Dr. Tolbert, Dr. Douglas Noble, who is the Associate Director of Public Health, Emergency Preparedness and Response at UNICEF, to provide his opening remarks. Welcome, Dr. Douglas, and thank you so much for honoring our invitation today. The floor is yours.
Thank you very much. I'm sure Dr. Rosaline and Dr. Tolbert will be online after this as well, and they can also make their remarks. Let me just start by saying good morning to everybody, colleagues, partners from different organizations, faith leaders. UNICEF would really like to thank Africa CDC, WHO, IFRC, all the partners supporting governments across the region in responding to the outbreak and strengthening preparedness in neighbouring countries. And I'd particularly like to acknowledge the faith leaders and faith communities that are joining us today, whose ability to reach and influence communities is extraordinary. And I trust that this session will be very helpful in terms of preparing us for responding better to the Ebola crisis. The current Bundibugyo virus disease outbreak in DRC and Uganda is a reminder for us that outbreaks are not only biological events, they're human events. They affect families, communities, relationships, often in places that are fragile, that are facing conflict or displacement, or health systems that are challenged. And with no licensed vaccine currently available for the Bundibugyo virus disease, our strongest tool remains early detection, infection prevention and control, community engagement, and public trust. Trust is often the difference between success and failure in an outbreak response. It influences whether people can seek care early, whether they follow public health advice, whether they adopt behaviours that protect themselves and other people. And experience from previous Ebola outbreaks has shown us that fear and misinformation and stigma can spread almost as quickly as the virus itself. I think that's where people here in faith communities have a unique role to play because of the position of trust that you have in society. You're able to offer hope in times of uncertainty and provide practical guidance that can help protect lives. When faith leaders share accurate information and encourage protective behaviours, you are powerful partners in preventing disease and strengthening community resilience. I just wanted to tell you one story last January, during the Ebola outbreak in Uganda, I visited a church in Kampala that's led by a friend of mine. And after the service, we were discussing my work on Ebola, and he said something very simple to me. He said, if we had more information about the disease, we would gladly share it with the congregation. And that really struck me that it represented a huge opportunity. Faith leaders who provide spiritual care, encouragement, and hope, but can also deliver practical support and trusted health information that protects people from disease. I was reminded that faith and action need to work together, and what we believe is made complete through what we do. And this means taking the values we hold and putting them into practice for the benefit of communities. And in a public health emergency, that action may be as simple as sharing accurate information, supporting safe practices, or helping a neighbour to access care. On the UNICEF side, we have a long tradition of partnering with faith actors. More than 100 country offices work with faith-based organisations in different ways around the world. And as an organisation, we've really seen the value of these partnerships in strengthening trust and supporting communities and improving outcomes for children and families. So as we face this outbreak, we really need all parts of society working together. And in this dialogue today and in tomorrow in French, by bringing science and faith into the conversation, I hope we can strengthen trust, counter misinformation, and really support the collective action that's needed to prevent the further spread of this disease. So thank you again for your commitment and for the partnership.
Indeed, thank you very, very much, Dr. Douglas, for those words. Faith and action need to work together, and emphasizing on accurate information, particularly at a time like this. Thank you so much. I now wish to bring in Dr. Francis Kuria, the Secretary General of Religions for Peace and the African Council for Religious Leaders, Religions for Peace. Dr. Kuria, thank you so much for sacrificing. I can imagine the time in New York, but thank you. We take note of your sacrifice and the moment is yours. Welcome.
Thank you, Rosilla, and thank you, friends, for all of those who have joined. Am I clear?
Yes, you are, Dr. Kuria.
Thank you. Yes, I wish to first by wishing all those present here, our distinguished representatives from the Africa CDC, World Health Organization, UNICEF, the International Federation of Red Cross and Red Crescent Societies, the African Christian Health Organization Platform, the National Religious Councils, religious leaders, our public health experts and scientists, colleagues, religious leaders, youth and women leaders. Good morning, wherever you are, good afternoon. It's really an honor and a pleasure to be with you this morning as we have this conversation on faith and science, on the Ebola prevention, preparedness, and community engagement in Africa. This collaboration between the African Council of Religious Leaders, Religions for Peace, and its partners, and bringing together all the religious leaders from across Africa is so important in addressing one of the key challenges that we face right now. On behalf of the African Council of Religious Leaders, I extend my appreciation to our partnership, especially with UNICEF, for whom we have collaborated for a long time in Africa and elsewhere, the Africa CDC, and the World Health Organization, with whom we have worked very closely together, especially when we're dealing with COVID and the conversations we had with COVID, and now with Ebola and the work we have done in the past. We gather at the moment the ongoing Ebola virus disease outbreak in DRC, and it's now spread to both Uganda and South Sudan, coupled with the challenges of the communities they are in. It does remind us that infectious diseases do not respect national boundaries. The elevated risk facing several countries across the Eastern and Southern Africa calls for vigilance, preparedness, and coordinated action. And in the coordinated action, that's where partnership comes in. We need to coordinate with all our partners in this region as we respond to this public health emergency. While Ebola as a public health emergency has taught us that it is also a community challenge. And scientific interventions alone cannot succeed without the trust, as Dr. Douglas has just said, acceptance and active participation from the communities. It's unfortunate some of the incidents that have been witnessed in DRC, driven by fear, lack of information, disinformation, and stigma, where communities are hiding cases where we have seen clinics attacked. All these are unfortunate incidents brought about by lack of adequate information and fear. Fear, misinformation, stigma, and mistrust continue to undermine these response efforts and can spread, and this can escalate the spread of the disease. And that fear can itself spread faster than the virus. Across Africa, religious leaders remain among the most trusted voices in society. During previous Ebola outbreaks and other health emergencies, including the COVID-19, faith communities have provided accurate information, supported vulnerable families, promoted health-seeking behaviors, encouraged safe and dignified burial practices, and helped reduce fear and stigma. For this reason, ACRL firmly believes that faith engagement is not an optional addition to public health response. It is an essential pillar of risk communication and community engagement. We are encouraged by the actions already being undertaken by our faith-bound networks, both in the affected and risk-prone countries. We especially wish to congratulate the Intelligence Council of Uganda, which has issued community and standard operating procedures to guide faith leaders in supporting Ebola preparedness and response efforts. In the DRC, the National Intelligence Council continues to mobilize religious leaders and community to strengthen awareness and promote hygiene practices, although not at the level we wish it to be. Together with UNICEF and Religions for Peace, we have developed a faith engagement community engagement package that provides practical guidance on Ebola prevention, pastoral care, safe and dignified barriers, addressing stigma, and countering misinformation. Today's dialogue is intentionally called Faith and Science in Conversation because neither faith nor science can succeed alone in addressing public health emergencies. Science provides evidence, surveillance, research, and public health guidance. Faith provides trust, moral leadership, and community presence, and the ability to reach people in ways that other institutions often cannot. When science and faith work together, communities are better informed, more resilient, and more willing to adapt to life-saving measures. This is why we value the partnership with UNICEF, WHO, Africa CDC, and our partners here. This partnership demonstrates that protecting communities requires a whole of society approach where scientific expertise and trusted community leadership reinforce each other. Together, we are building bridges between evidence and trust, between public health systems and the communities we serve. At a time when misinformation, rumors, conspiracy theories, and disinformation can spread rapidly through communities and digital platforms, we need to up our role as religious leaders because it has become very critical. I just remember, just 2 days ago, I shared on a separate platform about the importance of preparedness and quarantine measures. And fairly educated people wrote back saying that this is not true. This is a scheme, and therefore the provision of accurate information is very, very important. Throughout history, faith leaders have been called to guide people towards truth, wisdom, and hope. Today, we must continue that responsibility by ensuring that our messages are grounded in verified facts, credible information, and in the right language that people can relate to. The religious leaders must never become channels of fear, speculation, or misinformation. Rather, we must be trusted sources of accurate information that helps communities make informed decisions, protect their families, and support public health efforts. Our congregations look at us and to us for guidance. Let us therefore lead them towards the light and truth and avoid any situations that brings about fear, stigma, further confusion. I wish that we replicate what we saw in previous epidemics, what we saw in Liberia and Sierra Leone during the Ebola outbreaks there, and hopefully by our actions and our coordinated efforts, we can bring even this outbreak to very, very quick control in the shortest time possible, with the least loss of life and confidence in communities. Thank you so very much, and I look forward to a lively discussion this morning. Thank you, and back to you, Rosita.
Much appreciation, Dr. Kuria. Thank you so much for your leadership, and thank you. You ended by emphasizing the need for us to replicate learnings from Liberia and Sierra Leone so that we can be able to bring Ebola to a quick control. And you have mentioned that infectious diseases do not respect national boundaries. Very true. And that's why today we have about 6 countries who have joined in this meeting. We have Kenya, we have Zambia, we have Ethiopia, we have Uganda, we have South Sudan, who are all logged to this particular meeting as neighbors, and they need to coordinate and partner to address this Ebola outbreak. Thank you, Dr. Kuria. I now wish to usher in Dr. Tolbert Chile. I hope I've pronounced it right. Dr. Tolbert Chile Nyenswa, the Director of Pandemic Prevention, Preparedness and Response from Africa CDC. Thank you, Dr. Tolbert, for joining in this particular meeting, and it's now your time to provide your opening remarks. Welcome.
Thank you, Rosella. It's indeed a privilege and an opportunity on behalf of the Africa Centers for Disease Control and Prevention, Africa CDC, and my colleagues. I'm really honored and privileged to join this important Faith and Science in Conversation webinar on Ebola prevention, preparedness, and community engagement. I would like to express my sincere appreciation to ministries of health, as you just mentioned, from our countries, religious for peace, UNICEF, WHO, as FRC, faith-based organization for convening this timely dialogue at a very critical juncture for our continent. As we meet today, as we know, Africa is responding to yet another ongoing outbreak of Bujumbura Ebola virus disease affecting communities in the Democratic Republic of the Congo, and then fewer cases in Uganda. As I speak to you from Uganda, Kampala today, yesterday, Dr. Tedros, WHO DG, and the Regional Director for Emergency Response, Dr. Mary Rosalie, and myself visited the isolation Ebola treatment unit here in Kampala and met with healthcare workers that are providing services and community leaders. Currently, we are now at the Sheraton Hotel here meeting with ambassadors and other healthcare workers. And on behalf of our Director General, His Excellency Dr. Jean Kashir, we provide an opportunity and reassure the people that of Uganda and DRC, the Africa CDC, stand side by side with other organizations to provide the needed support that is needed. While the number of cases still evolving, the outbreak has demonstrated the persistent threat posed by Ebola and the importance of maintaining strong preparedness and response capabilities across the region. The confirmation of cross-border transmission has reinforced the need for coordinated regional action and heightened readiness among neighboring countries. the foreign outbreak presents unique opportunities and challenges that we've seen in other outbreaks. Speaking to you, I was the incident manager of the Ebola viral disease outbreak in West Africa that I was speaking about earlier by Francis and Douglas, where we led the outbreak response. At the time, we did not have therapeutics, we didn't have vaccines, and there was no medical countermeasures. But we put in place all of the public health countermeasures that we all know: test the cases, isolate them, treat them, provide safety for the contacts, provide food for communities, and give psychosocial support. So the current outbreak is characterized by fear, misinformation, and stigma and mistrust. And one of the things that we did in the West Africa response that I highlight specifically was working with religious leaders, working with community people, traditional people, to do safe and dignified burials. We started at a very, very tough stage where we had to resort to cremation because of community resistance. But as time went by, we adapt strategies. The adaptive capacity was able to make us to create even burial sites for Muslims, burial sites for Christians, and safe and dignified burials were practiced, and we were able to halt the outbreak. We are seeing very similar situation now in the current outbreak in DRC about people attacking safe burial teams and community people are agitating. So we need the religious communities to work together for us to stop this outbreak. Africa CDC has been working closely with the governments of DRC and Uganda, WHO, UNICEF, under the incident management system team support IMST to provide strategic, technical, and operational support to the national response. The IMST serves as a critical coordination platform, bringing together expertise across surveillance, laboratory systems, case management, infection prevention and control, logistics, risk communication, community engagement, and other response pillars. Together, the IMST, Africa CDC, is supporting alignment of partners, strengthening information sharing, facilitate rapid deployment of technical experts, and ensure that we work together as a team. Experience from previous Ebola outbreaks, as I just mentioned, have shown us that even the most robust technical response team can be undermined if communities do not trust the response or feel excluded from decision making. Communities are not passive recipients of public health interventions. They are our most important partners in outbreak prevention and control. This is why faith leaders are indispensable allies in public health. Across Africa, faith institutions are among the most trusted and influential structures within communities. Religious leaders have a unique ability to reach people where they live, worship, and seek guidance. During previous Ebola outbreaks, faith leaders played a crucial role in promoting early care seeking, promoting safe and dignified burial practices, reducing stigma, countering misinformation, and helping communities understand and adapt life-saving public health measures. At the Africa CDC, we continue to place risk communication and community engagement at the center of our emergency response effort. Through the RCC social mobilization behavior change, community feedback system, and trusted local leadership, we are working to ensure that community voices are heard and they are listened to. The partnership between faith and science is not optional. It is essential science providing evidence and solutions. And we've got to work together as a team to do that. Africa CDC remains committed to working with member states, faith organizations, civil society organizations, and development partners to strengthen preparedness, protect vulnerable populations, and ensure that no community is left behind with a collective safeguard of public health. Together, through solidarity, partnership, and community leadership, we can stop this outbreak, save lives, and build safer and healthier communities. And this is why this morning, while Dr. Tedros, the WHO DG, was speaking, he said, we are still catching up. The disease has outpaced the interventions, and we cannot do it when the religious community is not on our side. I thank you for your commitment and leadership, and I wish you fruitful deliberations. Thank you.
Thank you very much, Dr. Tolbert. And you've ended by ending that you need to have the religious people on your side, and definitely they are on your side. Their presence here tells it all. And all the good work that you're doing, you are on the ground. Thank you for informing us you're actually on the ground in Uganda and all that is happening. And the emphasis that Africa CDC places risk communication and engagement very, very central. And thank you also for sharing some of the adaptive strategies that were mooted and are now working to help in averting this Ebola outbreak. I don't see the other speaker who was also supposed to provide opening remarks from WHO. But I wish to bring this session to an end. If she joins us later, we shall give her a time to provide her opening remarks from WHO. Otherwise, we sincerely appreciate our distinguished speakers for all your thoughtful remarks, and thank you for framing the discussions and conversations for this particular webinar with clarity and purpose. So we now move to the first session. And in this first session, we are going to have presentation on Ebola prevention and preparedness. And we shall have this presentation from WHO. We have Dr. Patrick Ramadan, who is the Program Manager, Emergency Response. And I believe also we have Dr. Julian Ngondo, I hope I pronounce it right, the Risk Communication and Community Engagement Officer for WHO Africa Region. The floor is yours, and we are allocating you 15 minutes, so you know how to share this 15 minutes between the two of you. Thank you, the floor is yours. Dr. Patrick Ramadan, or if Dr. Julian Ngondo can begin the presentation.
Yes, good morning, good afternoon.
Good morning.
My name is Julienne Ngondo. As you said, ma'am, I'm the focal person RCCE at WHO Regional Office for Africa. Thank you for inviting us. I hope Dr. Patrick will join, because our presentation started with the epidemiological situation and we end with RCCE. While waiting, maybe I can go ahead. If you allow me, ma'am, I can go ahead.
Yes, please go ahead.
Thank you very much. So my presentation, I will try to share my screen. Can you allow me?
Yes, Sarah, please allow Dr. Noko.
Please go ahead. You can share.
Can you see my screen?
Yes, we can.
Thank you. So I'm really very honored to be here to present shortly in 5 to 6 minutes the role of community into preparedness and response to Ebola Bundibugyo virus disease. So why community matters? They are first responders, they are trusted voices, they are behavior changers, they link to the health system. All what they do are at the community. They are the backbone of the health system. So community engagement approaches that we use participatory risk communication, community engagement, two-way communication, community dialogue, feedback mechanism. We use also local languages and culturally appropriate messages to translate the science into understandable and culturally fitting in the context of our people. We leverage their community structures like the religious and traditional leaders, community health workers, local NGOs, the youth, the network, and now we have our young son, this Gen Z, that are our social media influencers. So for preparedness, our communities can work and give us the symptom awareness. They are able to prevent habits, prevention habits, risk awareness, and health education. They are strong. They know how to do it. They just need us to support them, to build their capacity, to offer them this knowledge, health literacy. They are good in how to understand the transmission of the disease, early detection. They support surveillance. We can also, in preparedness, we have to work with our community leaders to include them in planning and decision making. We have worked with them, they have supported research, even vaccine and therapeutic trials. Our communities are being on the front line, and they also support the research to understand the context, because we cannot respond if we don't understand the context of our people, if we are not humble, if we don't show empathy to bring our community leaders to support us to be better person, and also to deliver a very effective response. Trust is one of the key areas, and to build the trust, we cannot build trust if we don't give the responsibility to our community leaders to build the trust, to engage with community leaders and the youth and the association. They are the ones that should be in the front, and we follow them behind, because they know better their people, they know how to talk to them, they know what type of words, what type of sentence can really touch their hearts. So we have to stand behind our community leaders. And for the response, where I am now, I'm talking from Bunia in DRC, in the heart of this terrible outbreak that we are trying to respond and to give the hope to our communities. Communities are working in isolation support. They are giving safe care giving, promoting safe behavior, IPC promotion. They are doing it. They are also doing the community compliance of all the operation of the response, and they are supporting contact tracing during the response, where I am now in DRC. They are also fighting misinformation and rumors. We are using local leaders, social media. They disperse all the myths. They address all the fears about the treatment center. They are the ones that are accompanying people to the treatment center. We have taken community leaders to visit treatment center in Rampara, in Bunia, and in Mombwalu. Once we took them to the treatment center, they saw and they went back to their community and said, you can trust. You have to go to the community, the treatment center at the early beginning of the symptoms. So this is how the community leaders and religious leaders in the front, they are supporting the response here in DRC. They are also working to reduce stigma and supporting survivors. We have already had some good news. 6 survivors in Bunia. Today we have 7 that will be released in Yankunde Health Zone, and also 1 in Mombwalu, where is the heart of everything. So these people, these community leaders are really working on reintegration of these survivors and bringing them back to the community, and also clear the fear of the rest of the community to welcome back the hero that has survived from the disease. They are also providing psychological support, preventing the discrimination, encouraging early seeking and support long-term recovery. Our community leaders are taking us to understand that nobody should be left behind in this response. So my presentation is almost at the end, because I had only 5 to 6 minutes. I had to conclude and saying that the trust that we need to bring communities to take ownership of the response, our community leaders are the ones that are supporting to build this trust, but also reducing the resistance. We heard about the issue of the violence that we are experiencing here in community in DRC. Our community leaders are in front to bring people not to be scared anymore. We are not succeeding for now at 100%, but we think that these efforts of engaging our community leaders should continue. And now we have a strategy of scaling up all the activities. And this is how the main area of scaling up is engaging our community leaders. Now I have a personal thing that I want to say. Let me tell you that when I see a religious leader, how I feel I have this emotional security when I am scared. So be you the religious leaders, you are the one that give me the hope to leave my family, to work on this response. I'm so happy you are here, and believe us, we are going to support, we are going to work together. Thank you very much. Over to you.
Amazing. Thank you so much, Dr. Julian, for this presentation. And you ended it up with your own personal testimony and feeling to the religious leaders that they are the ones who hold the emotional security. And the news of the 6 survivors, I think this is a very welcome news. And the emphasis you brought out on what communities are doing, the communication channels they are using and all that. I think this is very, very rich for all of us. Thank you very much, Dr. Julian, and we really appreciate this presentation. We hope I know you'll be able to share with us so that we share with all the participants. Thank you. Sarah, I can't see my chat. I don't know whether Dr. Patrick Ramadan is in. If not, when he joins us, we shall still give him his time. Okay, all right. So we move to the next session. The next session is sharing by religious leaders, and they'll share with us the ongoing faith actions. We have leaders from Uganda who are in Uganda, and they'll share with us what is happening in Uganda in terms of the actions they're undertaking. So we'll have Mr. Charles Serwanja, who is from the Interreligious Council of Uganda. He's the team leader for public health and social measures. And Charles will also, after his presentation, we shall have somebody from Uganda Protestant Medical Bureau, a very important personnel, Dr. Emma Welike, who will also share with us what they are doing from their end in terms of being part of the network of ACHAP, but in Uganda. So you have 20 minutes to share between the two of you. So allow me now to usher Charles Serwanja. The floor is yours, Charles.
Thank you, Dr. Rosilla. I hope I'm loud and clear. Just checking.
Yes, you are.
Yes, good morning, good afternoon, good evening, everyone who is here on this call. Thank you for inviting us to be part of this very important webinar. Thank you to our partners, UNICEF, WHO, and all others. And of course, we want to thank SRL and Regions for Peace for convening this very important meeting.
Just a moment, could you turn on your camera if it's possible from your end?
Oh, okay.
Yeah, thank you.
I would like to thank Dr. Kuria for his remarks, because he highlighted some of the things we've done already, and I don't have to repeat that, but perhaps to dive into a few areas in addition to what he shared with all of us. Now, disease outbreaks of this kind, for us here in Uganda, we believe that even when they go silent, we don't have any room to sit back, and we've learned lessons over the years as Interreligious Council of Uganda in our country, that our geographical locations continue to present challenges to us as a country, from DRC, from South Sudan, and all the others. And of course, we also pose a threat to some of our neighbors on the other side, like Rwanda, Tanzania, and Kenya, maybe the others. Now, one of the things for us we addressed a bit some time back in the previous outbreaks, we realized the issue of capacity in terms of understanding what are these diseases are. Ebola, we've had COVID-19, we've had Mpox, and with support from our partners UNDP, we developed a faith leaders handbook on epidemics. This is more or less a capacity building tool in a very simple language, which can be understood by our faith communities, to try and understand and appreciate that we need to be very vigilant and of course pass on accurate information every time we have these disease outbreaks. But more recently is that we have had, our leadership has had conversations with the President, the government through the Minister of Health, and there was consensus from our council and the President and Minister of Health to cancel all engagements, all mass gatherings, if possible, downsize them as much as possible. We have our flagship event annually that we hold, the Martyrs' Day, which was also cancelled, but also scaled down to very small numbers that can be manageable for that event. And as I speak to you today, is Heroes' Day in Uganda. It's a public holiday. We were supposed to have a national event. It was also cancelled, and the information we have that only 25 people are supposed to attend that event at State House in Entebbe. So those are some of the changes that we have had from our side, and we've managed to ensure that all faith institutions and other stakeholders can now use virtual methods of broadcasting information, and of course, which is about limiting in-person attendance and of course close contacts among the congregations and also our clergy. In terms of community mobilization, sensitization, we've continued to have radio and TV talk shows, especially using the faith-owned radio stations and the TVs, televisions. Although in terms of coverage, they may not be so much into the wider coverage. We were still struggling with mobilizing resources to also venture into the secular TV and radio stations that have perhaps a more wider coverage in our country. We have also gone into integration and leveraging on any available opportunities. Recently, we had an initiative with support from the Minister of Health, where we are reaching out to the ghetto communities, the youth, the young people, but more or less focusing on the ghetto communities, the slum areas, in 3 districts, where about 240 faith leaders were brought together, but of course in different districts, in smaller numbers, and oriented around the issues of many other diseases, inclusive of the recent outbreak of Ebola in our country. And these religious leaders now descended into the communities of the ghettos, of the young people, in the slum areas, in the district of Kampala, Wakiso, and Mukono, and they were, of course, disseminating this information and acting as the trusted sources of information for these disease outbreaks. We continue also to enforce the standard operating procedures to ensure that every structure of our faith communities, the places of worship, have different points of ensuring that they have hand washing facilities at different points, and of course, smaller numbers of people are congregating around those places. We also, I think this was in preparation for what was coming. We didn't know. God works in a very mysterious way. In the book of Genesis, chapter 6, verse 9, when Noah built the ark on dry land, many people laughed at him, thinking he was a madman. How do you construct a boat on dry land? But forgetting that when the floods came, it was the madman and a few animals that survived. And the lesson we learned from this scripture is that always plan ahead, because it wasn't raining when Noah built the ark. So early this year, not knowing that we'll have an outbreak very, very soon, we had a very significant orientation of senior religious leaders from what we call the Virunga land districts that are bordering game parks and also bordering other countries like DRC. And surprisingly, Bulibujo was fully represented, Kasese, and those are the districts that are actually on the other side, where we have a few kilometers to the border to DRC, on the One Health initiative, finding a delicate balance between the interaction of human beings, animals, and our environment, and how we can manage that ecosystem to make sure that we prevent diseases from crossing from animals to human beings and vice versa. And of course, because of resources again, we only did that for about 50 senior religious leaders, and we were expected to go on the other side of Kisoro, Kabale, partly DRC, but also Uganda, because they're also interacting with animals within the game parks of that side. But since I have Dr. Korea here and Rosella, I suppose that he will look for some resources to allow us to continue with this agenda. Now, as I wrap up, because we have little time, in the Ebola outbreak.
As you wrap up, maybe you turn off your camera. I'm seeing it giving a bit of challenges.
Yeah.
Sorry for that, Charles.
Yeah, that's what I wanted. I didn't want to use the camera close. Now, as in 2022, because many of our the earlier presenters were talking about trust. In 2022, when we had the Sudan Ebola outbreak, a single family of 10 Muslims died after exhuming the body of their beloved person who had died and had been buried by the health workers, but they still went ahead to exhume that body and performed reburied it through using by ensuring that they fulfill the Islamic rituals. And consequently, this tragedy was a disaster. All of them passed on. And until Interreligious Council came forward, stepped forward through His Eminence, the Mufti, that all the Muslims accepted to desist from practicing those rituals. Now, this brings in the issue of trust. In Uganda, I don't know what it is in other countries, but in Uganda, I have been in the kitchen of these outbreaks, right at the community engagement, dialogues. I want to be very honest to this meeting that trust of health workers in our country here is really very, very minimal, very minimal. There are so disturbing perceptions that people think that when there is a disease outbreak, the health workers are trying to create an environment so that the UNICEF, the UNDP, the other partners and government, it releases money for them to eat. That's a terrible perception. And they have no trust for them. They were saying this to us in our face in the district of Mubende and Kasanda, where we are going to have a post-Ebola recovery engagement. And this is where it is important for us to embrace the issue of fronting religious leaders as trusted messenger. And for me, I came up with a trusted messenger approach, where we front our religious leaders. They are the ones who can transmit this information, this scientific information, in a language respectful to the communities, but also ensuring that the cultural and religious beliefs of the communities they are addressing are respected. This is very, very critical. And we were told that right in our face. The challenge of infodemics, social media also, playing against all our interventions all the time, and until the trusted messengers come on board. But right now in Uganda, while we're talking about trust, that's saying religious leaders are trusted, yes, but what is the practice? As I conclude, the practice in Uganda is that we are sometimes brought in very late when things are going wrong. That's when people start stampeding to look for Interreligious Council of Uganda to bring them on board. So I want to end by saying that I think it is very, very important that we start from together in terms of coordination, in terms of planning, because in the Virunga landscape there, we are supposed to constitute what we call the One Health teams. These they are equivalent to the district interfaith networks. These One Health teams, we believe, will work closely with the districts in those areas to support government in terms of risk communication, of course, and community engagement to make sure that we do not lose the war against the outbreak of the diseases. Thank you, Rosilla. Briefly, that's what I have to share with you. Over to you.
Thank you very much, Charles, and congratulations for all the work you're doing as the Interreligious Council of Uganda. Thank you for sharing your partnership with the President, the Ministry of Health, and all the measures that are being taken, including the Heroes Day today, which you've told us has drastically been scaled down. Even the Martyrs Day, I remember in Kenya, people had already started walking from Kenya, Kanu to Namugongo. But when this outbreak came up, they were all stopped, even here in Kenya, and they could not proceed. Thank you even for mentioning what you're doing using the faith-owned media, the challenges you have shared, and the emphasis on trust, and unpacking it in terms of the way it is currently in Uganda. That mistrust of health workers, I think, is something that is coming out that as partners we need to take up. And trust has been mentioned even by our speakers during the opening remarks, and Julian also really expounded on it, being live on the ground in DRC. So trust is really coming up as a very, very essential concern that if tackled well, then we shall be able to move in the direction we need to move. And thank you also for the Virunga sharing, managing the ecosystem, and the emphasis on the One Health team and the importance of this One Health team. Thank you. I don't know whether Dr. Emma is here. Yes, I'm told Emma is here. Dr. Emma Welike from Uganda Protestant Medical Bureau. Feel very welcome, Dr. Emma. I hope Charles did not swallow all the 20 minutes. I'll give you some 6 minutes to share your presentation, then we move to the next session. Dr. Emma works with Uganda Protestant Medical Bureau. The floor is yours, Dr. Emma.
Okay, thank you very much, Dr. Zila. I don't know whether my slide presentation is visible on your end.
Not yet. Please share.
Just a second.
Okay, it's here.
Okay.
All right.
Just a second.
You put it on slideshow.
Okay.
Okay, perfect.
Thank you very much, Dr. Zila. My name is Emma Welike. I work with Uganda Protestant Medical Bureau. I will try to fit within the 6 minutes allocated to me. So, Uganda Protestant Medical Bureau is a faith non-profit umbrella organization that has a network of 331 member health facilities and 17 training institutions across Uganda. As we can see the map on my left that highlights the distribution of these facilities. So our facilities are largely drawn from the Protestant faith, including the Anglican Church, the Seventh-day Adventist Church, as well as the Pentecostal Church, and a few leading organizations. And we've been in existence since 1957. Just straight to terms of Ebola virus disease, case update, of course, in Uganda, this is already public information. As of Friday, of course, there are 18 cases, of which 14 imported 5 Ugandans. And just the details there, I just wanted to highlight that of the cases, we noted that 2 cases have been identified and linked to Mulago National General Referral from a member health facility in a Kampala region. And then 1 case that was a suspect in West Nile from one of our member health facilities was equally followed up, and the test turned out negative. So I thought I would just share that update and maybe highlight more on what we are doing in relation to Ebola prevention, preparedness, and response. So for what we've done, we've been able to do trainings on Ebola virus disease, and as well as the support CMEs and some of the facilities. And largely, we so far have focused on hospitals and health center force, prioritizing these facilities around the belt of the borders next to the Congo border. And we've also been able to go ahead and really support, strengthen the weekly surveillance in these member health facilities, especially those along the Congo border for the start. And we've seen leveraging our WhatsApp groups as a key strength for us to ensure that the reports are coming in on a weekly basis, and of course ensuring that these are actually reaching the Ministry of Health data capturing systems. We've also managed to do some distribution of a few job aids, which is ongoing, but that's still an area which is not yet fully covered. We leveraged the already functional IPC committees to do risk assessment in the different hospitals and health center forces. This was done across the country. And we are really seeing to it that we support, strengthen the hand washing and, of course, monitoring of the temperature, largely leveraging the patient entry points. We've seen the same systems that work for COVID working, at least for now, ensuring that hand washing is done through the different, across all the different entry points of the different facilities that we have, especially the hospitals and the high volumes. PPEs, however much, have continued to be a challenge. As for now, we are looking at how do we rationalize to ensure that the service delivery points that have the highest volume of clients, the OPD, emergency and the likes, having access to PPEs is among the things we're ensuring will support the facilities to do. In terms of risk communication and community engagement, through our executive director, we'll be able to share out a memo to the UPMB as an organization, institution, but also to our member health facilities 331 in regards to the preparedness, communicating and guiding on preparedness, but as well as prevention and response in case there is aspect. Looking at the WhatsApp groups I've mentioned, but I really wanted to mention on the risk communication. So far, we've been able to really see that we share the materials largely in soft copy, both mail and WhatsApp, to ensure that the teams are utilizing this. And of course, community engagement continues to happen as we've guided our member health facilities to participate in the community forums, radio talk shows, the different engagements, including at the faith institutions, but also at the district task force meetings where the coordination continues. More on collaboration and coordination team, we are continuing to participate in the national coordination meetings. We recently had one last week that brought together ministry, the Department of State, as well as some of our partners like FHI 360 that have equally also continued to support us in strengthening our capacity. And largely this is in Chigezi region. We as well continue to really partner with Mulago National Referral and the testing laboratories, and that speaks to the support we've been able to ensure that the linkage of the cases is done and treatment commenced, but also ensuring that the suspects are actually tested for confirmation. Particularly for Kabale region, we are closely working with them. We have daily meetings coordinated by the Kabale Public Health Emergency Operations Center, giving us updates and guidances, and as well providing an opportunity for advocacy for support such as PPEs and issues around coordination managed within that particular region that has actually been the focus of the cases so far, majority of them. Now, to summarize, on the slide is just looking at our next steps. We're looking at training the decision health coordinators largely as on, of course, prevention, EVD prevention, preparedness and response, but also given in the high risk regions, we had focused on the high volumes of the health hospital and center force. We're now looking at really cascading these trainings or CMEs as well as the lower level facilities, and this is going to include both Chigezi and West Nile and Toro region. Of course, I can't say more as Charles had talked a little bit more on faith leaders, but we're really looking at how we're going to leverage the faith leaders to strengthen the risk communication and community engagement. Radio talk shows that's something we're also planning to really strengthen, particularly for the affected regions, to really see that we enhance risk communication as well as community engagement. For surveillance, that's something also we want to cover. We are seeing now Kampala having a case. So in order to ensure that all the facilities as well routinely preparing, but also screening and reporting to have the surveillance component fully function in the rest of the facilities is the next step, as well as ensuring that whereas this response and is happening, the routine health service delivery is not compromised. So it's something as well we are working to ensure that we're going to support the facilities in to organize their response and prevention response, prevention and preparedness around not leaving out any routine health services delivered to our communities that we serve. I thought I would just highlight a few areas for support. Of course, PPEs, as I mentioned, is still quite an issue, not sufficient, especially for the regions that are on the border of Congo, but also some of the materials largely we are using soft copies and a few hard copies. So we think having a few of the hard copies around job aids, IC materials, and a few thermometers. I thought I would end with this, Dr. Roselia. So just a few of the pictorials for some of the trainings or the CMEs happening. Otherwise, thank you very much, and I expect to stop.
Much appreciation, Dr. Emma. That is amazing work you're doing on the ground and on the 3 areas you have highlighted. And thank you also for sharing the next steps and also the challenges that may hamper some of the interventions you're trying to undertake within the various healthcare facilities. Dr. Emma Weliki, as I've said, comes from Uganda Protestant Medical Bureau, and I believe this is part of ACHAP, the Christian Africa Christian Health Association platform, is it? I hope I'm correct. And this should be the Uganda chapter. So thank you for that session. And the active contribution of faith actors has been lauded by our esteemed speakers. And what is coming out clearly is that bridging of science and faith through meaningful community level interventions. Thank you very much. And we commit that we shall share all these presentations with all of us. The essence of all these sharings is for us also to know who is where and how we can continue to partner even in our different corners to combat this Ebola outbreak. We now move to the next session because we are trying to also be sensitive on time. And the next session is on risk communication and community engagement. And this is going to be taken up by UNICEF. And we shall have Mr. Massimiliano Sani. We like calling him Max because his name, Massimiliano, is long sometimes for us. That's Max. Max is the global lead for the global team for social and behavior change, UNICEF. And he's going to do this presentation together with Aru Badnaga, who is also the SBC lead in emergencies. So this is your session, and thank you very much, UNICEF, for your support, the co-creation together with all the partners to make this webinar happen has really been appreciated from our end. So I'm giving you 15 minutes so that you share with us the RCC priorities, all those social listening that you've come across, and the role of faith engagement in RCC. Thank you. The floor is yours.
Thank you so much, Dr. Rosilla. Thank you, colleagues, and appreciation for all the speakers and the participants and the amazing work that actually is already happening, especially when we saw the session in Uganda from both the IRC and the HACCP member. So really, really inspiring. And again, the scope of this collaboration is to create more links and more synergies so that we can accelerate the overall response. We will try to be brief, and basically our presentation will focus on core facts on BVD, Ebola, and the symptoms, and so basically core RCC messages that have been actually developed jointly with WHO and FRC and Africa CDC, and then some SEL, social and community listening insights and community insights that we have tracked so far, and also, again, the role of faith actors, as Rosilla said, including introducing a faith engagement guide that we have actually developed together with the partners represented here for in-country adaptation, so that we have also a tool to use with your own communities, and obviously for in-country adaptation and co-creation. So I'll give the floor to Aru for the first couple of slides. So Aru, over to you.
Thank you. Thank you so much. And good morning, good afternoon, and good evening, colleagues. It's such a pleasure to be here in this event and having the honor to speak with in front of honorable religious leaders and getting to hear from them in terms of how critical religious leaders have been. And I've also had the honor to work with several of you during the West Africa, Sierra Leone Ebola response as well. So it's really nice to see that we're still on it and we still emphasize the role of religious leaders and platforms that are so central when we are trying to engage communities. I'll quickly take you through the core facts about BVD. I'm sure all of you are aware of that, but it's good to kind of keep reminding ourselves what are some of the key messages that we have worked with WHO, IFRC, and Africa CDC. And before I begin, there is a set of RCC messaging guide which exists. So if you've not had a copy, please let us know. We would be very happy to circulate it around. It's in French and in English. How BVD spreads? Of course, we all know it's a highly contagious virus, and it spreads through direct contact with body fluids, particularly blood, vomit, stool, sweat, or saliva. And someone who is sick or has passed away, or through contact with contaminated objects like surfaces, clothing, or beddings. Next, please. And who can spread BVD? A person who can spread BVD after symptoms begin. Hence, the importance to watch out for symptoms and seeking care immediately is very important. And I think a lot of speakers have alluded to this, is watching out for symptoms and making sure that care is immediately available for the person who is showing the symptoms. Next, please. How does it not spread? And I think this is a very common question, which is also coming in our community listening and community feedback is it COVID? Is it Mpox? So very, very important, and I think very important to communicate this message to say it does not spread through air. People cannot get BVD from praying together, by sitting together in services, or through casual social gatherings or greetings like handshakes and hugs. So it's a little different, and very, very different actually from COVID. And I think communities are still recovering from COVID and Mpox. But let's be very, very clear when we are sending this message out. Next slide, please. Of course, I mean, everyone's aware and concerned about the vaccine fact, and currently we do not have a vaccine available for BVD, but we have a vaccine trial which is undergoing and it is considered safe. and of course is going to be very, very pertinent and critical to this response. And I can assure you that there are teams, the research and development teams that are working on it day and night to ensure that we get a vaccine as soon as possible. Although just to state that the absence of a vaccine also leads to a lot of heightened community anxiety, leading to rumors, leading to misinformation, which several other colleagues have mentioned about. Early care is the key. That is something that we are expecting, and sending and disseminating the messages through our community-based platforms is going to treatment centers as soon as the symptoms appear, gives the best chance for survival. And we all know that. And early treatment also helps to protect family members and communities. Here, we also like to focus on women and children. We know that women are primary care holders and primary household people in the house, primary caregivers at the household level. They are the first ones who take care of families. So it's very important that we communicate through women-based networks, through female women religious leaders, as well as youth groups, to ensure that we keep them central to our response. Of course, what are some signs to watch for? There's sudden fever, tiredness, muscle ache, sore throat, loss of appetite, stomachache, vomiting, or diarrhea. And if anyone experiences 3 or more of these signs, they're required to report it to a healthcare worker. Yes, and people tend to confuse BVD with malaria as they present similar symptoms. And I think that's exactly the reason why there are a large number of suspected cases coming out from the community, and making sure that they do not confuse BVD with malaria. Bleeding may only occur in some patients, and people should not wait for bleeding before seeking care. A little different from the previous EVD outbreak. People do become contagious only once the early symptoms begin, so the risk of transmission substantially increases as illness progresses, especially when there's some wet symptoms that you can see, for example, diarrhea or vomit or any other body fluid start. So just in a nutshell, those were some of the key messages, just reminding us in terms of what are some of the, how do we communicate to the communities, and what are some of the key messages. Now, I know a lot of speakers have spoken about preparedness and action, and Douglas spoke about community-centered approaches. How do we keep the communities very, very central to the response? And Dr. Tolbert also mentioned about faith in action and rumors and misinformation. Now, these are some of the community insights from DRC and Uganda. These are insights from the Infodemic Management Insight Daily Reports from WHO and UNICEF. And I'll quickly take you through this, just setting a little bit of a tone in terms of how should we be focusing on our program planning and implementation around SBC. So one of the community insights that has been coming out is low trust and misinformation. Rumors and mistrust are hampering the uptake of services, and I think everybody here is going to agree to that. With the sudden outbreak of the disease and with rumors with no vaccine, there is mistrust happening in terms of should they go to the services or not. Health workers continue to be the most trusted channel so far, but reported PPE gaps, and I think our colleague just before we came in, they did mention that there is lack of supplies and for PPEs, and I think that is a very important point that we need to look into, and cases amongst health workers are hampering trust in Uganda. So this is an insight which has come from Uganda. Next one, please. Poor community perceptions. Still in DRC, the EU report that we conducted a poll of about 50,000 and over respondents, 64% still don't know what the transmission routes are, 63% don't know how to protect themselves, and 17 say they don't believe the disease is real. And I think this is where the religious leaders' work is very, very important, ensuring that we want to tell them that the disease and the impact of the disease is real and can impact families, communities, and households. Resistance to response measures. Of course, there is a resistance towards isolation. There is limited contact tracing. IPC measures are not as strong as we would want them to be. And of course, safe burials. Let alone on this, we also have attacks on the healthcare workers and also on the treatment units. Attacks in families, people rejecting Ebola diagnosis. So I think there's a lot there which is creating a barrier towards also we approaching the communities in the most responsible way. And this is something where, yet again, leveraging upon faith-based groups, leveraging upon faith-based actors becomes very important. Next, please. Delayed care seeking and hidden cases. Fear, stigma, and use of informal care is slowing down detection and reporting. And 29% of the EU reporters would not accept a recovered patient into the community. And we know that this could be such a bottleneck if the acceptance rate is very, very poor. Working with survivor groups, and yet again, I look up towards the religious platforms, working with the survivor groups is just so important, and improving the acceptance and mitigating the risk of being ostracized from the community. And we saw that a lot in the West African Sierra Leone outbreak, and also in the previous outbreaks as well. Next, please. Mobility and cross-border dynamics, extremely important. I know we have countries which are at a heightened risk and are working towards preparedness. Population movement complicates surveillance and engagement, and we are working with cross-border platforms as well, and ensuring that there is consistency in terms of the messaging that we're sending across. And like I mentioned, women and children should be central to the response. And that's all. Over to you, Max. Thank you so much.
Thank you so much, Aru, and morning again, colleagues. Just for the sake of also the time of the allotted to us, and also looking at the, since we are slightly behind, I will try to be brief, but basically I wanted to introduce a little bit this kind of multi-country faith engagement initiative that we are obviously working together with the Leaders for Peace, Africa Council of Religious Leaders, and ACHAP as well. The idea, and all the partners that have been presented today, the idea is really to bring faith and science together, and this comes obviously with the recognition that faith actors are critical for building trust. We heard that multiple times. They are obviously the best communicator since centuries, and so you actually know how to promote preventive behaviors, you know how to actually detect rumors and address them, if equipped obviously with the right tools, and also support the community-based surveillance. That's also another important part. Beyond the core, let's say, RCC part, risk communication, community engagement, there is an important role for faith actors to also support community-based surveillance and the safe and dignified barriers that we also hear from IFRC colleagues. Our partnership also, and basically has enabled us to develop a joint faith engagement guide, and I put a link here for in-country adaptation and co-creation. We will share the link also in the chat as soon as we stop, we end the presentation, so that actually the teams and the colleagues from the different faith actors can work and adapt this guidance, obviously in coordination with the local Ministry of Health, which is always important to ensure that whatever we produce at global level, at regional level, it's fully adapted for the specific in-country context. Now, just before entering into the key content of the guide, I just wanted to mention that obviously our collaboration with Leaders for Peace and Africa Council of Religious Leaders comes from a significant number of years. Actually, now it's already like since at least almost 10 years that we have a long-standing partnership, and this has built also us to operate quite fast. The problem that we have usually when there are emergencies, that we have to establish new partnership with different key influencers or groups, civil society organization on the ground, and this takes time. And so having a long-standing partnership, it allowed us to just adapt basically our normal programming that we are already doing with RFP and ACRL, to ensure that actually we are covering also this important topic, and basically we respond together to Ebola response. So basically on the role of faith actors on RCC, I will be very brief because also my colleague from WHO, Julien, speak it very clearly. Faith actors are the voice of truth and calm, so they can share accurate facts clearly. The faith actors can dispel panic. They can basically address anxieties and stop harmful rumors before they spread. This is very, very important. We have to be careful also even what we circulate on social media ourselves as individuals, because if we are not sure that if those rumors or posts are true, we are actually amplifying basically misinformation, even if maybe that's not our intent. Obviously, faith actors are champions for early health seeking. You can actually promote that type of behavior, and this will be a direct contribution to saving lives. As soon as symptoms appear, really the communities should go to the health facilities and ask for support and for care and treatment. Obviously, pillars of compassion, and this is particularly when obviously during the darker side of the Ebola response, when there are obviously the obituaries and the funerals, and you can definitely play an important role in supporting without actually judgment and try to address the fear that communities are facing. And they are the bridge of trust. We heard it multiple times, so that's I won't go into the details of this, but obviously this is a critical component to continue building trust in the between, again, the development sector, the Ministry of Health, the response itself, and the communities. And the guardians also the tradition, so that's why it's important to ensure that we are also taking into consideration local tradition and religious habits into the response itself. And obviously, they are also essential partners in health. We heard from ACHAP member in Uganda how important it is also to ensure that those networks of faith-managed health associations are also part of the actual response. So that's very important because, first of all, they are managing health facilities, but they also play a critical role in the overall response. Now, again, focusing on stigma and false rumors. Stigma is a key bottleneck for Ebola, and so if spiritual leaders stay silent, people think that the disease might be shameful, might be inexistent, or might be a curse or a punishment. So it's important to really speak up, and it was very nice to see from Julien in the DRC confirmation that actually basically RCC messages are being shared in the Friday prayers, in the Saturday and Sunday also faith gatherings by the partners. And it's important also to name it, the Ebola with compassion, all the overall impact of the Ebola, and help communities understand that actually the Bundibugyo virus is a medical disease caused by a virus that spread through direct contact with infected body fluids. Welcome survivors home. This really gives a lot of hope. And now we're starting to see the first cases of survivors being basically discharged. It's important to ensure that they are not stigmatized. They are not infectious. And so that's why we should welcome them back home. And say the truth repeatedly. Again, a person cleared by doctors is completely safe. And so particularly, and also their family members. And even if they have lost like a parent, the children should be supported, and you know how to do it also through your social networks. And again, address the stigma publicly. I think this is very important to avoid that it further spreads. In terms of pastoral care and community action, give the grief a voice, dedicate sacred time in religious services for people to voice their sadness, confusion, and worry, seek out the isolated safely, and bringing prayers and comfort to their doorstep, keeping a safe physical distance, obviously, but at the same time still be with them during those terrible moments that Ebola unfortunately brings to some families. And learn, obviously, from your sacred tools. You know how to comfort communities through songs, through prayers, through the scriptures, and this is obviously something extremely important to address mental health issues also that this outbreak is generating. And again, severe distress, so that particularly identify those community members that are particularly in distress, that those that are maybe even in despair, speaking of self-harm and so on, so that we can actually support them meaningfully. And then obviously for safe and dignified burials, that's a critical role of faith actors. I won't go into in this slide because my colleague from IFRC will cover it after us. But I just leave it here because it's one content of the guide that we just are going to release, so that you know that these are the key sections, core facts of Ebola, what to do, what are the roles of faith actors, and then all the different pillars that of the response in which faith actors could be involved. So I'll stop here. Thank you so very much. And back to you, Rosilla. Apologies for extending slightly. Thank you.
Thank you. Thank you, Max and Aru. Thank you so much. UNICEF is the technical arm of the Faith for Positive Change for Children, Families and Communities initiative. And I like the angle that this conversation is taking. This is a real mind, faith and heart conversation taking place. We've heard of scriptures being mentioned, technical part in terms of data, in terms of information around symptoms and all that. Very, very important has been shared, and even personal stories, personal experiences in terms of combating or responding to this Ebola from our different corners are being shared, and we really appreciate. So thank you, Max, for mentioning the face guard that has been co-created by all of us as partners. And of course, I believe countries will be able to adapt and co-create. The highlights of the sections is very, very important. And I think this now motivates all of us to really utilize this guide. The criticality of religious leaders in trust, in promoting preventive behaviors, in ensuring that they remain the voice of truth and calm has properly been emphasized by you, Max. And Adu, thank you for keeping your ears on the ground so that you were able to get the community insights from both DRC and Uganda. I'm told Dr. Patrick joined us. Dr. Patrick, I'll give you an opportunity slightly later. After this session that is coming up, Dr. Patrick was supposed to be providing a presentation for us under WHO on Ebola prevention and preparedness. But allow me now to move to the next session, then we'll come back to Dr. Patrick, then we end with questions and answers. In the next session, we will have a presentation, as Max has hinted, on the role of faith actors in promoting safe and dignified burial practices. And this opportunity or this presentation will be done by IFRC, Celestine Ogutu, who is the coordinator for public health and emergencies. And the floor is now yours, Celestine. I know you are here with Eve Stephanie Galeo, so I believe you know how you share out your time. 15 minutes, but try to make it even 10 minutes if possible. Thank you. Welcome.
Okay. Thank you so much. My name is Celestine Ogutu. I'm the Public Health and Emergencies Coordinator for IFRC Africa region. Kindly confirm you can see my screen.
Yes, we can see you.
Okay. So thanks so much, the presenters from UNICEF. You highlighted some core facts about this BVD and other presenters also. So I'll just start with what is safe and dignified burial. This is a public health intervention that is there to protect the family and the community members when the burials are being conducted. But it's done with respect and also respecting the cultural and the religion of the person who has lost their lives. So we make sure that these people are protected, the ones that are present when these burials are happening. So why do we need the safe and dignified burials? It's because there is a high viral load at death. So the BVD viruses are shed in body fluids that are most infectious at the moment of death, persisting for days on surfaces and fluids. And the transmission through funeral rites, whereby when we wash and touch the bodies of the deceased, we are providing that exposure environment for us to get the virus to our bodies. And also there's a proven impact. Introducing a safe and dignified burial at the start of an outbreak has been shown to reduce infections and break the chains of transmission. Also contaminated environment such as the bedding, clothing and personal effects of the deceased can harbor the virus and require safe decontamination. And there is also a balance between safety and dignity, whereby SDB is not about abandoning tradition, but about adapting practices to protect the living while honoring the dead. And that's why we normally encourage the religious leaders to be part of the process when the SDBs are being conducted. Okay. Next. I don't know if my slides are moving.
Celestine, sorry, we don't see it in full screen, so you would need to put it in full screen. Or yes, now we see the next slide. Yes, perfect. Thank you.
Okay. All right. Sorry about that. So we did a rapid qualitative volunteer perception survey where there was a need had across communities, and this was what was highlighted in that rapid qualitative volunteer perception survey, that across multiple locations, Red Cross volunteers named safe and dignified burial, wanting more information, better preparation, and greater confidence in supporting their communities through it. We've had a series of volunteers being attacked when they are conducting this SDB. So we call upon the religious leaders to help us on this, because we work together, and when the SDBs are being conducted, the religious leaders are normally present, and your voice can also influence the communities to be able to protect our volunteers when they are conducting these SDBs. So faith actors are community members responding in their communities, and data shows that they are among the best placed to support community engagement around safe and dignified burials. So why are we important as faith leaders during the safe and dignified burial? You can see in that pictorial, we have the SDB teams, we have the family members, and we have the sheikh present to conduct the burial rituals before this body is buried. So the religious leaders are trusted community voices. They interpret doctrine during emergencies like this PVD, and also their direct participation in the burial helps to calm people and also trust the process of the SDB. And they also support in countering rumors and misinformation, as mentioned by UNICEF and other presenters during this webinar. And also they provide psychosocial and spiritual support before the outbreak, and also during the outbreaks and after. So the religious leader, you have a key role to play also in providing psychosocial support, and also prepositioning communities. When we are in preparedness mode, we have a role to play, just like it has been mentioned by a presenter from Machap, that they were engaged when there was no Ebola, that they have a role to play, passing this information to community members. So we have a role to play in community awareness, including SDB processes. So adapting burial practices, trust building, cultural and religious consideration. The core principle is that no burial begins without family consent. This is the foundation of trust with every family. And we normally encourage our SDB teams, and it is also part of our protocol, to not to have the protective gears before talking to the family members. So they normally do it. They share their condolences with the family before they wear their protective gears. This shows that these family members are also seen as human beings and not just like any other thing that is happening. No. We encourage the SDB teams to offer condolence, greet the family members, and also show that remorseful that we've lost a person in this family. So funeral practices carry deep meaning. Burial and mourning rites are central to cultural and spiritual life. Disrupting them causes lasting grief. Communities must be consulted, not simply told what to do. And something else, washing and touching the body. In many cultures, ritual washing and touching of the deceased is obligatory. SDB teams must understand these practices and offer safe and meaningful alternatives. That's why we normally have the religious leaders present to also share the information on modify the way we can modify burial. Trying to avoid that touching and washing of the body that normally happens when there is no outbreak. And also Muslim adaptation, dry ablution, the tayammum, I hope I'm saying it correctly, replaces water-based washing. Shrouding in white cloth is maintained. Prayers are observed at graveside, all within infection control boundaries. And also Christians, they also do their modification by families may view the body, sprinkle blessed water place scripture with the deceased, and invite a pastor to lead prayers without physical contact to the body. Community consultation is essential, so rapid cultural assessment through CAP surveys help identify which practices can be safely adapted and which need substitution, reducing community resistance. So best practices so far from the previous outbreaks, because IFRC through the national societies have been doing this for a very long time. So we've done pre-identification substitution rituals using rapid cultural assessment at the early beginnings of outbreak has allowed teams to agree on acceptable alternatives with religious leaders in advance. And also from West Africa Ebola 2014 to 2016 outbreak, involving religious leaders in planning, transformed acceptance and improved reporting of deaths. And also the 2018-2020 DRC Ebola outbreak, the SDB teams embedded community engagement specialists and co-designed burial ceremonies with local leaders, resulting in lower refusal rates and greater family participation. And the last best practice that we noted is that faith leaders as public ambassadors, they figure who publicly endorsed SDB in affected areas, reduce community hesitancy, and encourage early reporting of deaths, a critical factor in containing outbreaks. So community engagement in practice, what this looks like for SDB. Participation, co-designing of adapted rites with family. The religious leaders, the pastors, the sheikh, are to be present to agree with the family what is going to be done for us to avoid the resistance by the community members. And then feedback mechanisms, we have channels for families and communities to ask questions about SDB. That's why we normally have the public health officer and other technical people present, and also the community engagement and accountability officer present as a part of the SDB team to be able to answer questions from the family members. And then the open, honest communication, community meetings and religious gathering used to introduce the SDB processes. Like right now, we are welcoming you guys to help us to pass the message about the safe and dignified process, how it is done. We can pass this technical guidelines to you guys for you to help us. And also community understanding, to understand local burial practice, beliefs, and the role of the faith leaders. The risk communication in epidemics, tracking community perceptions and beliefs about Ebola and burial, and using faith networks to respond with trusted, timely information like this webinar. So thank you, and I don't know if my colleague has something to add. Yves?
Thank you very much. Thank you very much, Celestine Ogutu, for that presentation. And thank you for highlighting the fact that SDB, that is safe and dignified burial, is a public health intervention to protect families, communities, and is usually done in a culturally sensitive manner. Thank you also for sharing some of the best practices. That's why these presentations are very, very important. We'll share with all the participants. And you have also emphasized the role of religious leaders to protect volunteers when conducting the safe and dignified burials. So Celestine is from the IFRC, that is the International Federation of Red Cross and Red Crescent Societies. I wish, Dr. Patrick, kindly, I wish to apologize. We may not have time because we only have 10 minutes to the end of this webinar, but we request you to share your slides, and we invite you tomorrow because we have another session with Francophone countries tomorrow, and we'll have interpretations, so we shall slot you in also to make a presentation if that is okay with you, Dr. Patrick. Kindly bear with us. Participants now, we've listened, we have shared our comments on the chat box. I have seen collaborations, partnerships being promoted in the chat boxes, mentions of the continental RCC meetings going on, so that this will continue reinforcing the partnerships. Invitations have been extended. From the chat boxes, you see the different organizations that have joined in. So that interest of partnership and coordination has really been emphasized by what has been jotted in the chat boxes. So at this particular time now, I want us to use the next 10 minutes for question and answer. So anybody with a question, you can raise up your hand. You can even put some on the chat box so that our able presenters can be able to respond to them. Just 10 minutes. So the floor is open. Any questions? Going one, going two.
Hi, Dr. Rosira. Good morning from this end.
Good morning, Sivas. It's still morning from our
end. Thank you very much for the wonderful webinar that we have been privileged to attend and listen to what is happening around us. You would love to know that Zambia is bordering a lot with the Congo, DRC. We have 4 provinces that are bordering the Congo. My question is there anything that is in the pipeline to help us seal this borderline in terms of building the capacity of our religious leaders on the border provinces that we have in Zambia? We have 4 provinces that are bordering with the Congo. It's a very long borderline. We hope we could be helped to ensure that we seal this line. I don't know what is in for us on that side.
Thank you, Sivas, for your question. Maybe if any of the partners can respond. Zambia, the Interreligious Council there are requesting whether there can be capacity build for religious. Max, your hand is up.
Yes, thank you. And I see Patrick also perhaps want to complement Dr. Patrick. Maybe just from UNICEF side, just to say that all the country offices working in the high priority countries for preparedness beyond the DRC and Uganda have developed risk communication and community engagement plans internally, but also contribute to support the Ministry of Health to develop the overall Ebola response plan together with WHO, with FRC and all the partners. And so it would be very important, I think, for the interfaith councils and also the member of ACHAP to be part of those RCC working groups that have been activated to see what type of detailed action are being planned. It would be difficult to provide an answer on the, specifically region by region or province by province from our side, but I'm sure that by first of all, sitting at the RCC working group, that would be the first step to be integrated in the response. I'll stop here and then Dr. Patrick perhaps want to complement. Thank you.
Yes, thank you, Massimiliano. I would like to agree with you. So Zambia is one of the priority countries categorized as priority 2, and there are ongoing activities to scale up preparedness and readiness in Zambia. My recommendation would be one, as you mentioned, the engagement within the RCC pillar, but I think also deliberately the coordination mechanism should prioritize engagement with the Interreligious Council and have a deliberate plan for passing the messages to them, equipping them with the right messages that they should be able to pass to the
to the congregations in the different areas where they serve. So I will pass on the message to our colleagues in the country office in Zambia.
Dr. Patrick, you are breaking a little bit.
Yeah. No, my final message.
We didn't get the last part, Dr. Patrick. Sorry, you are breaking a little bit.
Okay, I was saying that I will pass on the request to our colleagues in Zambia so that they can reach out to the Interreligious Council and include them in the ongoing preparedness and readiness activities. Over.
Perfect. Thank you so much. Thank you, Patrick, and Dr. Patrick and Max for the response. Charles, your hand is up. Go ahead, Charles.
Yeah, thank you. Thank you. I hope I'm loud and clear.
Yes, you are.
Yes, I want to thank all my colleagues, all of us here for the submissions we've made. Thank you for those insights. Now, from what I feel from here, we all seem to believe that the religious leaders are critical players in the emergency response. But I think sometimes this is contradicting with the actual practice. Like I said at the beginning during my sharing, I have been in the kitchen when it comes to these disease outbreaks for some time. And whenever we have an outbreak of this kind, you usually see, a lineup of medical workers, Minister of Health, and all doctors, so and so only, and making the pronouncement. And for us, the piece of information we picked from the community engagements is that their perception is that these are issues for doctors. There's a lot of words say basao. You're a doctor, so those are your issues. And they seem to detach themselves from what is happening because of the limited integration of other players within the response. And therefore, this over-medicalizing the response mechanism, the planning, the coordination, I think has significant consequences. And I'm asking, how do we really strengthen our multi-sector response? How do we ensure that we are doing joint planning together, the coordination of all players, and how do we ensure that the religious leaders are sitting on the table on the national and district task forces where planning takes place, and they are there from day one, other than coming in late when things are not going on well, because that has been a practice most of the time here in Uganda. Thank you.
Thank you, Charles. I think you've thrown some food for thought for all of us to avoid making the initial mistakes. We should now think of how are we ensuring that religious leaders are involved from the word go in planning and all the other processes that we are now talking about. He's saying we now have to be practical. It's high time now we became very practical. It's food for thought for all of us. If your hand is up, Rodwell, then we end it here because time is now not on our side.
Thank you, Dr. Rosella, for giving the floor. And thank you, Charles, for raising this very important point, which is to make sure that religious leaders are involved right from the word go, which is what we are advocating at the risk communication and community engagement level, that we need everyone to, or let's say all the partners, to be fully involved from the word go. And I think what we can do is, let's take the case of DRC and Uganda right now, is that we need to start to do a lot of advocacy so that religious leaders can be part of these decision-making groups. For example, in DRC, I know there was a coordination meeting taking place, I think it's every Tuesday, but let's say twice a week. And we need to see how we can first identify what are the religious network in country who can be their representative, and then we do advocacy so that they can be part of it. And by so doing, I think they can also participate in helping us to refining the operational plan we have in country or the strategic plan we have in country, and they can also come up with what are the action or activities that they can carry out. And from there, partner can see how they can align and also support this religious network to better support the entire coordination or the entire operation on the work we are doing. So I think that's what we need to do, really advocate so that they can be involved in the coordination meetings. Thank you.
Thank you, Eve, for that. And I think it will also be important for the focal contacts, probably of the coordination teams, to reach out to the focal contacts of these interreligious councils. I think that way it will also be easier for them to now find themselves logged into some of these coordination structures. I think it will be important, maybe after this meeting, to share the focal contacts for religious leaders and also the various coordination structures. Thank you.
Yes, on this one, Rosila, in terms of commitment, UNICEF and I'm sure that also the colleagues from WHO and FRC would probably agree to do the same. We can share the contacts of all the IRCs, right, the Interfaith Council of Religious Leaders in these 12 countries, but also the ACHAP members with our own country offices to, again, promote this type of collaboration so that actually we, the more support, the better, and more integrated, more trust with communities will be generated for sure. Thank you so much.
Thank you. Thank you for that, Max. Thank you. All right. Time is now up. Rodwell. Rodwell, half a minute so that we go to we should now be moving to the closing remarks and way forward.
Well, basically, I think my comment has been taken. I just wanted to add to say, even the religious leaders themselves, they should not wait to be called. I think the internet of the faith leaders, we need to take a lead as well, not to wait to be called at the last minute when things are in a disaster mode. But the two previous speakers have actually talked exactly what I thought the interfaith is actually a very good response to such challenges.
Perfect. Thank you very much, Rodwell. It should be two-way. So the challenge is in all our courts. Yeah. But immediately after this meeting, we'll follow up. So before we get to the closing remarks, I just wish to really thank you all for your very active participation and very insightful presentations and very, very rich sharings as I provide a summary of the key takeaways from this webinar. First of all, the critical role of religious leaders and faith communities as trusted partners in Ebola prevention, preparedness, and response efforts across Africa has been highlighted and emphasized. And the discussions have also underscored the importance of effective risk communication and community engagement in addressing misinformation, fear, stigma, and mistrust surrounding the BVD outbreak. And of course, participants, you have noted the culturally sensitive and faith-informed messaging, which remains as key if we have to improve community acceptance of prevention and response. And there has also been a mention aligned with this, the need to also include local languages if we have to communicate meaningfully to the communities. This webinar has also stressed the urgent need for strengthened cross-border, cross-district coordination and regional preparedness within our various countries and also across our borders. And of course, the invaluable contributions of faith actors in community sensitization, psychosocial support, and also promotion of safe and dignified burial practices. The mobilization of women to make visible their voices has also been emphasized, and the need to ensure support for children, including the orphaned and also the vulnerable as a result of this outbreak. Now, we have also all acknowledged the unique challenges posed by the current outbreak, including the absence of a licensed vaccine. And this increases the importance of prevention, early detection, surveillance, and community engagement. The lessons learned from previous Ebola outbreaks have been shared as important guidance for strengthening current preparedness. Last but not least, the webinar has reaffirmed the importance of sustained dialogue and partnerships between faith and science institutions, as well as the need for continued coordination, information sharing, joint planning, joint actions to protect communities, build synergies, and enable resilience against Ebola outbreaks in the region. And lastly, and very, very important, the need for us now to ensure we are all involved or engaged in the various coordination structures. Thank you very much. As I now usher in again Dr. Francis Kuria. Thank you so much for being patient all this time. Kindly, it's now your time to provide the closing remarks and appreciation. Welcome, Dr. Kuria.
Thank you, Rosilla, and thank you all the partners who have participated in this webinar, all the participants, all the countries that have participated in this webinar. This has been a very wonderful discussion and conversation. As we come to the end to this important webinar, allow me to express my very sincere appreciation to all our presenters, panelists, and participants. It's really been wonderful. We have had important updates on the current Ebola virus disease outbreak, the risk landscape and the preparedness measures, how our partners and experts are doing the community engagement strategies, and the critical role of field actors. Several key messages have emerged from our discussion. First, that we need to treat Ebola preparedness as a shared responsibilities with government, health institutions, field actors, development partners, and other members of society. Secondly, we must understand that and deal with misinformation, fear, and stigma, which remain significant challenges, and the role of religious leaders is crucial. And faith engagement must remain central to risk communication and community engagement efforts. And we thank all the partners, UNICEF, WHO, Africa CDC, and others who are engaging religious leaders. But of course, we have heard that we need to engage them quickly. But also, we need to, the religious leaders need to be proactive and not to wait to be invited, but they themselves need to reach out to these ministries and be at the forefront. Fifth, we need to really have ourselves the accurate information, and we must guide ourselves. We must guard ourselves and guide ourselves with correct information and be proactive in fighting disinformation. And then, in terms of building trust, religious leaders must remain focused and in communication, and must use the interfaith mechanisms to ensure that everybody is included. All these are important issues, and I think we are going to be following them up. Charles, we have heard you of the need to support the gaps that are existing. We work with our partners, and also you need to work with the in-country teams to see that the resources can be unlocked nearer where you are, but we are going to be working with you on some of those issues. I wish to encourage all the participants to take the knowledge and resources shared and to move forward, especially the religious leaders, and engage their communities well. So thank you so very much. It has been a very wonderful meeting and webinar. We hope to have a second webinar tomorrow addressing the French-speaking countries. And we hope with this, the African Council of Religious Leaders, Religions of Peace International, and our partners, WHO and UNICEF and others, are going to really bring this new outbreak into control very, very soon through preparedness, prevention, and response. So thank you all very much, and we wish you a good day for the rest of the day. Thank you, and God bless you all.
Thank you so much, Dr. Kuria. Thank you, Dr. Rosilla. Thank you, everyone. Have a good day.
Thank you, everyone. Thank you so much. Have a good day. And thank you so much, Dr. Kuria. Bye-bye.
Thank you.
Bye.